We're going to talk about the concept of inflammation and how it relates to appendicitis and inflammatory bowel disease. So really, inflammation is just the body's immune response to an actual or perceived threat. So this could be something like an actual threat like a virus or an injury, or a perceived threat like peanuts, right? Could also be a response to your own body, like an autoimmune disorder your body perceives as a threat, but it's actually not. So we're going to talk about a couple of those today. And just as a review, the first thing that will happen when your body is perceiving a threat, let's take a mosquito bite for example, is going to constrict the blood vessels around in that area. Then you're going to release chemicals like histamine to dilate those blood vessels. You'll start to see redness, maybe some heat. After that, you start to release proteins, white blood cells into the tissue around that area, and that's very aggravating to your nerve endings, so you might notice some pain, you'll see swelling. Over time, if it gets worse, that's going to form exudate or pus. And then the last stage is the healing, which is when you start to form that fibrous scar tissue in that area. So that's the whole process of inflammation. So we're going to start by talking about appendicitis. So your appendix is this weird little appendage that hangs off of the end of your large intestine, right where your large intestine meets the small intestine. We don't really know what kind of purpose it serves. Some believe it's a reservoir for normal flora. Regardless, we can live without it because we often remove it. It doesn't really hurt us until it becomes inflamed or infected. And so that's what we're going to talk about, that inflammation of that little appendix. The signs and symptoms are pretty classic for appendicitis. The pain is the number one symptom that people complain about. It comes and goes in waves and then eventually becomes constant, and it becomes localized to the right lower quadrant of the abdomen. And it's very, very painful. It's sudden, it's an acute pain. This is not something that came on over months, it came on over a day or two. So people are going to probably be in the fetal position with their knees flexed. They can't even lay straight because that's painful. But that pain will be in the right lower quad. We call that McBurney's point. They're going to complain of rebound tenderness. So you press down in that area. They may not have a lot of pain, but when you release it, it becomes very tender. They may also have fever, loss of appetite, nausea, vomiting. That abdomen may become very rigid. So our diagnosis comes a lot from that physical exam because of those very classic symptoms, but we will also do some lab work. So the CBC is going to probably show an elevated white count with a left shift. That means that we have greater than 75% neutrophils. So that means your body's quickly pumping out new white blood cells. That means there's probably an acute infection going on that happened very suddenly. They may also have bands, greater than 7% bands, and bands are just very, very immature white blood cells. It's kind of like the white blood cells that didn't finish boot camp, right? They just got kicked out while they still had a pacifier, and they're not really doing a lot of good. And it usually means that it's a bacterial infection. So we're going to do some diagnostic tests. We'll do x-rays, ultrasound, but really the classic diagnostic test that you'll see is the CAT scan, the CT scan, and that's going to give us our definitive diagnosis. We may suspect peritonitis if the person complained of severe pain and then suddenly they're telling you, you know what, I feel better now. And that might mean that that appendix is actually ruptured. So there's all that tight inflammation and suddenly it ruptured and they feel better. That's not a good sign if suddenly they feel a lot better, because that rupture, if we go back, if this ruptures, then we have now whatever is in this bowel is leaking out into the peritoneal cavity, which is supposed to be a sterile environment. So they may end up with peritonitis. So if we suspect that peritonitis is happening, we may also get blood cultures and a lactic acid level. You want to make sure they're not becoming septic. Really, the only treatment that we have for appendicitis, besides, of course, giving antibiotics, is to remove the appendix. This is an emergent surgery. This is not something that we're going to wait around for. This is the type of surgery that if it's 3 o'clock in the morning, we're calling the OR team to come in and do. Because if we wait, then we run the risk of that appendix rupturing. We want to get it out as soon as possible. Usually this is done laparoscopically through a few small incisions, and it's a fairly standard surgery. It's, done all the time, so the outcomes are very good, whereas, 100 years ago this was a common cause of death. If the appendix has ruptured, we may need to do an open surgery where we open the abdomen up to remove it, but that's uncommon. So like I said, the complications for this would be perforation and peritonitis. Alright, so now we're going to get into these inflammatory bowel diseases. These are both autoimmune disorders, meaning your body is attacking itself. So there are some differences between the two, so I'll go over that and we'll, emphasize that when we meet together. So Crohn's disease involves the entire alimentary canal, from mouth to anus, and the inflammation extends through the entire bowel wall. So you're going to have a lot of scarring, and that bowel is going to lose its flexibility. It's not smooth like it used to be. It starts to get this cobblestone looking appearance. You start to have a lot of cracks and fissures in it. And all of that and all of the scarring prevents the absorption of nutrients, so this person's going to have a very hard time getting the nutrients that they need through eating. So they are also going to have right lower quad pain, but remember, this is chronic. This is a lifelong condition. This is not something that's ever going to go away, so not like appendicitis, which is acute and will go away. So this person may have semi-formed stools or diarrhea 6 to 8 times a day. They're going to be pussy, probably not have blood in them though. You may feel what feels like a mass in the right lower quad just from all of that inflammation of the bowel. They may have fever, especially if they're having an acute exacerbation of this. Fatigue and malaise are classic symptoms of just about every autoimmune disorder that we're going to talk about. They're going to have weight loss, anemia because they're not able to get the nutrients that they need. So think about all those nutritional anemias that we talked about. And they may form fistulas, which is that artificial pathway that the body creates between two incompatible organs, like the bowel and the bladder. It's going to make its own little hole, and then bowel movements can travel into the bladder or into the vagina and leak out where they're not supposed to, and that can create a lot of risk for infection. So that's one of our major complications with this. So ulcerative colitis is a little bit different. It involves only the colon, so usually just the rectum and the sigmoid colon, but it can involve the entire colon. It's also not full thickness the way that Crohn's disease is. It only affects the mucosa and the submucosa. So that being said, it is not any less severe than Crohn's disease. It has some pretty terrible symptoms associated with it too. So this person is going to have extreme diarrhea 5 to 30 times a day. So think about fluid volume deficit, electrolyte imbalance. There's going to be major concerns for this person. They're going to have bloody stools, unlike Crohn's disease, that they usually just have mucousy, pussy stools. They're going to have left lower quadrant pain, which is different than the right lower quadrant pain. They will also have anemia, like our Crohn's disease patients. Low albumin, they may have a high white count, especially if they're having an exacerbation and there's an ulcer and it's infected. Weight loss, sometimes the weight loss is pretty extreme. And uveitis, so that's an inflammation of the middle of the layer of the eye. You might see like red eyes. So our diagnostic studies for inflammatory bowel disease are going to be our lab work. We're going to look at the CBC. It's going to show us that anemia from the malabsorption. You might see a high white count. You might see a lot of electrolyte imbalances because of all of that diarrhea, right? Especially the sodium and potassium. The albumin and protein may be low. The sedimentation rate is going to probably be high. And that shows us that there's inflammation going on in the body. The liver function test may be elevated if there's cholangitis, which is inflammation of that bile duct. We might do a stool analysis just to look at mucus, see if there's infection in the bowel. Helps us rule out other things like C. diff, for example. And we may also look to see if there's blood in the stool. We may do a sigmoidoscopy, which just looks at the sigmoid colon, or a colonoscopy, which shows us the entire colon. An EGD will show us, that's an upper endoscopy, so show us the esophagus and what's going on in the stomach. And then a barium enema will show us the mucosal patterns and will tell us the depth of the disease. Because remember, Crohn's disease is full thickness, and ulcerative colitis is just the mucosa and submucosa. So that might help us differentiate between the two. So our treatment is going to be multifactorial. So remember, these are both autoimmune disorders. So depending on the severity, we may treat with some or all of these things. So aminosalicylates, the one that you'll see most often is probably sulfasalazine, or mesalamine, blah. Those reduce inflammation. We may give antibiotics if there is an infection going on. And when you think antibiotics for the treatment of inflammatory bowel disease, we want antibiotics that work well in the gut. So the ones that you'll probably see most often are ciprofloxacin and metronidazole. Those are going to be your two top ones. We may treat with corticosteroids, which is something that we'll have to do sometimes with autoimmune disorders that decreases inflammation. Steroids are wonderful and terrible at the same time, right? They decrease the inflammation, they make the person feel so much better, but over time they can do a lot of damage to organs. They can also cause a lot of GI upset, and they can raise the blood sugar. So classic ones that we may give are prednisone, prednisolone, hydrocortisone. Immunomodulators do just what they say. They modulate the immune system. The thing with them is that they take a long time to start working, maybe 6 months sometimes before you start seeing results of that. But this is something that they're going to have to be on for the rest of their life. We want to get this person in remission and prevent them from relapsing. So if they suddenly stop taking these medications, they're probably going to relapse, and then when we try to get them back on them, those medications may not work. So that's some education that we need to do. Once you start, you can't stop. Biologics are the monoclonal antibodies, so those are your MABs. So anything when you see M-A-B at the end, so like infliximab, golimumab, they're kind of hard to say. Just remember, MAB at the end is going to be your biologics. Those work great too. Same thing with them though. Once you start, you really can't stop taking them. We may also give immunosuppressants, which do just what they say. They suppress the immune system. So I need you to think about the same things where we talk about cancer. It's almost like neutropenic precautions that we need to educate these patients on, because they really don't have an immune system. So they need to, or their immune system that they do have is being very suppressed. So they need to avoid crowds, good hand washing, not eat fresh fruits or vegetables, all of those things that we talked about before.